Okay, welcome folks to the May 27th edition of the Cash Patient webinar. I am Charles Frohman, sitting in for my co-host Jeff Cantor, who is planning with one of our Your Freedom Hub partners down in Tennessee. And that is our sponsor, and there's the website, yourfreedomhub.com. And if you want to register for all of our email previews that come out Monday, there's your link there, yourfreedomhub.com/cashpatient, capital C and capital P. And Dr. Levien's webinar tonight will be available by Sunday at these three platforms, at YouTube, BitChute, and Brighteon. And if you did go there at YouTube at least, here are some of the past webinars that you'll see, a whole bunch going back almost a year and a half now, every Wednesday. That one with Dr. Davis there, I particularly encourage folks to check out because he consults practices how to get more cash patients and not be so beholden to third-party payment, employment in hospitals, or the whole rolling over dynamic with lobbying and protectionism. So that's partly what we're going to discuss tonight with Mr. Levien. And he is the CEO and president and board chair of the American College of Health Trustees. He's a consultant at bestindustryresearch.com and CEO of Advanced Healthcare Consultants, and a fellow at the American College of Physician Executives, now has a different acronym. He's also, I believe, and he can tell us, someone who's dabbled in the benefits world. And he's just a talented all-around guy. And I especially like his stories from directing surgery centers, surgery departments at several hospitals in and around Philadelphia. So with that, David, I am going to stop sharing and allow you to share your screen and take it away.
Well, I want to thank you very much, Charlie. And let's see here. Okay, can everybody see my screen now?
Yep.
Okay. Well, I want to thank Jeff Cantor and Charles Frohman and the Freedom Hub for inviting me to speak tonight. Just to let everybody quickly know my background, I spent 33 years as a surgeon, 20 of which were as a chairman of surgery, and 12 of which were as a program director of a surgical residency, teaching doctors who've graduated from medical school to become surgeons, and teaching medical students. And so I have a lot of people have asked me about what gives joy at work, and many people have sent their children to me to advise them about whether they should go into medicine in what's considered a somewhat hostile environment with lack of autonomy. And the age-old question, should you follow your passion or should you take a tried and true course where you could make a living? And of course, it's been said that if you follow your passion, you'll never work a day in your life. And the other side of that equation is if you don't do something where you can make a living, you may be eating dog food in your retirement. Now, as it turns out, most people aren't going to starve to death practicing medicine. Different specialties have different earning power, And the point is that nobody's going to starve. And as long as you don't go into medicine for the purpose of getting rich, you're likely to have a satisfying career, especially because there's a sacred relationship between the doctor and patient, and that must be preserved. And in a day and age when our treatments are more effective than they've ever been before, there's still a tendency for the doctor-patient relationship to fall apart. And some of that is because we've lost our priestly function. And there's no reason why we can't be both high-tech and high-touch. When President Eisenhower had his heart attack, there wasn't much that could be done for him, and it wasn't very expensive. He had supplemental oxygen, he had morphine, he had rotating tourniquets, and that's it. And now we have the ability to open up your coronary arteries, to treat you with expensive anticoagulants, to do drug-eluting stents, and give all of these expensive treatments. Yet we must not forget that a very important part of healing is done by the laying on of hands and by being empathetic. And there's no reason we can't do both. So this is Sir William Osler, and he talks about the refreshment of the medical society and indicates the irony that the busiest physicians have the least time to partake of the refreshment of the medical society. The people who need it the most often don't have the time to do it. And of course, Osler wrote in his valedictory address at the University of Pennsylvania, he wrote about equanimitas, and that became the title of his book, Equanimitas. Thou shalt be a promontory against the sea, immutable. So that when Dr. Bloggs walks into the room, everybody says, thank God Dr. Bloggs is here. Now everything's going to be all right. And so many medical students applying to my residency program asked me what I was looking for in a candidate to the program. And so many people ask this because I believe it's written in a book that that's a question they should ask. And I always told them that it wasn't what I was looking for when they came to the program, it was what I was looking for when they left. That when they walked into a room, everybody say, thank God, Dr. So-and-so's here. Now everything's going to be all right. So there's a chap named Dr. Peter Valenzuela, and he's the chief medical officer of one of the hospital chains in California. And he has the site I would recommend to everyone. It's called Doc Related. And if you just Google Doc Related, you'll go there. I'm happy to send anybody the link. But it's very funny, but also gives significant insight into how doctors feel about administrators. And of course, my opinion is that we all need to work together, physicians, nurses, executives, vendors. But in any event, you can see the caption says, the administrator says, great news. We found a way to address your request for additional support staff. And the doctor says, awesome. What support am I getting? And the administrator says, we're enrolling you into our resilience training program. The doctor says, how's that going to help me? And the administrator says, it will teach you to do more with less. And then the doctor is thinking here, sounds like more work with less resources. So it's important to have insight into the relationship And that's a pretty prevalent feeling among physicians and surgeons. Now, here was a study done by the RAND Corporation in 2018, and it was a study of the effects of payment models on physicians. And what they found, the key findings were that the payment models were changing so quickly, it was difficult for physicians' practices to keep up with the new advanced payment models. And they were increasing in complexity. And there were some practices that invested a lot of money in keeping up with these models, and they would get increased payment, but they really didn't change patient care. So they made some recommendations. The first one was to simplify the advanced payment models, and I couldn't agree more. Slow the pace of change, consider offering only upside advanced payment models, and designing with input from physicians, and I couldn't agree more that physician input should be sought. And lastly, if you have cash-paying patients, you take these third parties out of the equation and nurture the doctor-patient relationship, and that might be the best solution of all. So what is an expert? An expert is someone with slides who lives more than 50 miles away, and consultants in hospitals and medical practices are somewhat like that. So John Madden says, a consulting position might work in another possession, but not in pro football. There's no such thing. They give a guy a parking spot and put his name up as a consultant, and in 6 months they erase his name. And I think John Madden is right when it comes to hospitals too. A hospital, a consultant comes in, charges a lot of money that can be used to hire more nurses to improve patient care, and then leaves when the proverbial excrement hits the fan. And if hospitals and administrators are a little bit more proactive, they should have the talent among them to figure out the problems themselves. So this talk is supposed to be about joy, and you see here a picture of chimes. And some years ago, I had a conference in Philadelphia, and it really addressed all the traditional things on our American College of Healthcare Trustees curriculum. It addressed compliance and ethics, human resources, information technology, quality and safety, business decision-making. But I figured that I wanted to stir things up a little bit. And I had a physician from the Philadelphia area come in, and she played the chimes and talked about joy. I think joy is very important, because without joy, I believe that physicians, nurses, and other hospital personnel won't be engaged. So a joy is a feeling that one's own value is appreciated and loved by others, that you feel useful, capable of productivity. And these are all factors of enormous value for the human soul. And that's a quote from Maria Montessori. And it's sort of like the Ritz-Carlton model of human resources. You treat your employees well, and they'll treat your customers well. Well, there's ample evidence that in a healthcare setting, if you treat doctors, your nurses, your therapists, your housekeeping staff, if you treat them well, they'll treat the patient well and improve the patient experience. And everybody here is familiar with the triple aim, but we and others have made it the quadruple aim. So the triple aim is to provide care that has high quality and safety, that has a good patient experience, and that's financially sustainable. And we also believe it also needs to provide a good experience for associates. again, doctors, nurses, therapists, housekeepers, administrators, and that if they're trusted and treated well, they will treat the patient well. So again, I think joy at work is absolutely critical. I think it's important to have an understanding of how physicians are perceived, how society treats physicians. And here you see classical Norman Rockwell paintings, and you see a very kind and empathetic physician, but he also is somewhat paternalistic. So the good part about him is that he fulfills his fiduciary responsibility, the Hippocratic oath, to put the patient's needs first, and that is important and must be preserved. Now we're a little bit less paternalistic than we once were, and believe in shared decision making. I still feel that you need to make a recommendation to your patients, not just give them the statistics, but then you don't become withdrawn when they decide that their reality is such that they'd like to take a different course. So I mentioned earlier that I've interviewed well over 1,000 people for slots in my surgical residency over 30 years in education, and invariably and they all fill out a personal statement. And I don't believe in personal statements because I believe it's making the applicant jump through hoops and say what they think you want to say. And occasionally you'll see a personal statement that's really creative, and you think, hey, this kid's really creative. Maybe he's going to be a wacko. I don't want him in my program. I don't really think that way, but I've read every single personal statement of people I interview because if we're going to write them, I think we're obligated to read them. But almost to the one, they mention a mentor, a surgeon who was influential in their life, and secondly, they mention that they want to have a feeling of efficacy. They don't necessarily want to take care of people who are slowly deteriorating from chronic conditions. They want to do something that they feel is meaningful. And of course, here you see a picture of somebody removing an appendix. And on the right, you see a picture of a virus with the various proteins. And, everybody here has heard the epidemiologist giving opinions, and many of them, if not all of them, have never taken care of a sick patient and probably become very anxious if they have to take care of a gunshot wound or a bowel obstruction or a patient with a Crohn's fistula. Well, again, I think it's very important to understand what society wants in their physician. And some of you who are older may have seen Marcus Welby, the smiling gentleman in the white coat. And again, very kindly, very paternalistic, which is now considered a negative thing. But again, he was ethical and always fulfilled his fiduciary responsibilities to put the patient first. On the right side, you see House. And I rarely watch doctor shows on TV, but occasionally my wife is watching it when I come home from work, or was watching it. So I've seen House a few times. And of course, House does things that none of us could do. We would be stripped of our license within seconds of behaving like he behaves. But yet his TV patients seem to love him, and viewers seem to love him. And be interesting if anybody has any comments to hear why people feel that he's so well loved. And in my opinion, people love him because he concentrates on their problem, and his whole team devotes their entire energy to that single patient's problem. Something that almost no physician could do these days, because they have a 15-minute encounter. The patient may have 5 or 6 medical problems, and the physician has to fill out an electronic medical record, and half the time they're a data entry clerk with their head buried in the computer screen. And it really doesn't appear to the patient like the doctor's interested in them at all. And that is really, and I have some strategies that physicians can use to combat that. But the main thing is that as a healthcare executive, you need to create an environment that nurtures the doctor-patient relationship instead of crushes it. So some of you might have seen ER, and again, I might have seen it once or twice, and there seems to be a lot going on there among the physicians. And of course, I had young house staff, and they keep me young, although I doubt the goings-on were quite as extreme as among these crowd. My younger brother, was an actor, and he was the star of his own series. It was called Doctors' Private Lives. And he was the star, and his co-star was a very famous actress whose name I forget because I don't usually remember these things, but she was very well known. And it only lasted 4 episodes, even though it had great reviews, because there was a writer's strike and only 4 episodes were written. But having said that, I told him that the Doctor's Private Lives really just a big yawn. It's not anything like was depicted in his TV show. So how do we find joyfulness at work, the zenfulness, the yin and the yang? And without getting too spiritual here, I think it is important to be individuated, to find mindfulness at work. But sometimes I think a more practical suggestion is to put on blinders. So you're a physician and you walk into the operating room for a patient with a complicated Crohn's fistula or a bowel obstruction, a hostile abdomen, or you walk into a waiting room, or not a waiting room, an examining room with an anxious patient with a lot of problems. In the latter setting, and even in both settings, you need to put on blinders and devote all of your attention for that period of time to the problem at hand, and put out of your mind all the extraneous factors that are impacting on your life. So maybe your kid's college tuition is due and you don't have it, or the malpractice premium is due and you don't have it, or your teenage child just wrecked the car and he's okay, but the car is a total wreck. All of these things that might produce anxiety and distraction have to be put out of your mind. You need to put on blinders, and you need to give that patient your undivided attention and your empathy. If we teach our residents, if you walk into the examining room, first thing you do is look the patient in the eye. Second thing you do is introduce yourself. Sounds simple, but often forgotten. And the third thing, which is very important, is you give the patient a chance to tell you their problem in their own words. If you don't do that, whatever you do for the rest of the visit, they're going to be unsatisfied. The average time a physician gives a patient to tell them what's troubling them is something like 9 seconds, and that's inadequate. You need to give them 2 minutes to tell you what's troubling them. Now, 2 minutes may seem like an eternity, especially if they start talking about things you don't consider relevant. But that's part of healing, is to give them their time to express what's troubling them and not fire off questions within 9 seconds. So you get the subjective part of the database, you do your examination and get the objective part of the database, and you formulate an impression and you articulate a plan. And you also articulate a secondary plan in case your plan doesn't work. And then you give the patient a few minutes to repeat the plan back to you to confirm understanding. So that's my story, and I'm sticking to it. So if anybody would like to ask questions, I'm most pleased to answer them, or make comments for that matter.
Thank you very much, Dr. Levien. And folks, as I sent you in chat, if you see that hand raise icon around your Zoom controls, please click that and I'll call on you starting on Mr. Paul Roberts. Go ahead.
Yeah, great presentation, David. Just wanted to start with that. You know, you had mentioned the bedside manner, and that is very important, especially in gaining the patient's confidence. When we talk about surgeons and, you know, kind of how things are changing with the landscape of healthcare, can you comment particularly regarding the prospect of universal healthcare? And if I know obviously, you know, many of us on this call want to go in the direction of the free market healthcare system versus the universal healthcare system, but at the same time, forces that be are kind of dragging us in that direction as well. How does that, or how could that change the landscape in your view?
Well, that's a great question, Paul. And by the way, your video on healthcare is outstanding. Well, universal healthcare is an expression that's misused. So we really have taken care of everybody that presents to us. First of all, in an emergency room, it's illegal to turn anyone away until you've stabilized them. Secondly, I know in my 33 years, I never turned a patient away, regardless of their ability to pay. And I've operated on plenty of people at 3 a.m. for a bowel obstruction or an appendix that I knew didn't have the ability to pay me. And I agree that it's easier to do that, to get up at 3 a.m. after you've gotten home at 8 o'clock at night, and you know you have to be at work at 7 a.m. anyway for your routine. It's easier to do that if you're going to get paid and it's going to help you buy sneakers for your kids. But you do it anyway because you have to live with yourself. And part of my job is, my 20 years as chairman of surgery, is to make sure that our emergency room was covered and that there were people of every different surgical specialty to take care of the problems that presented. But I think you're asking a different problem, because the fear, if there's a single payer, is that he who pays the piper calls the tune. So if there's a single payer, the fear is that government bureaucrats will control healthcare, and they'll tell you who can get a hip replacement, who can't. They'll tell you what the practice parameter is, and that can be very destructive. That truly is cookbook medicine. And they even talk about death panels. And conservatives are accused by the liberals of being hyperbolic, but death panels really were created, and they were never implemented, but they were created. And the government agencies have a amount of money that they feel should be spent for a year of high quality life. And if a procedure isn't going to provide that, they feel that you shouldn't have. And most of us feel that those decisions should be between the physician and the patient, not between a government bureau. And in 1979, I worked in the National Health Service in the United Kingdom for a year, and it was very interesting. The National Health Service, and I'm getting a message that my internet is unstable. Can you hear me?
Yeah, we can hear you. Thank you.
Well,
Yes, that's pretty common, that message. Go ahead.
yeah, but we're having a thunderstorm, which is why I'm taking it seriously. So they felt that, well, first of all, you'd be on the waiting list. It would take a year or more to get your hernia repaired. And then you could get called on a Friday and be told you come in Monday to have your hernia. If you say, I can't, I have a small business that I'm running, I need to plan ahead, then you go to the end of the waiting list. And the joke was that when you have a kid that's born, you sign them up for their total hip replacement in their public school, because that's how long the waiting list is. So I think that that a government-run system is problematic. On the other hand, I personally would never turn a patient away for the inability to pay, and they tend to get the most expensive and patient-unfriendly care imaginable. Often they have to go to an emergency room for their care, and that's expensive, and they're often there all day, because if they don't have a true emergency, they're going to get bumped by the gunshot wounds and the GI bleeders and the ruptured aneurysms. And it's pretty hard to land a job if you have to spend your entire day in the emergency room.
Well, we appreciate your service.
Federally funded health clinic.
Yeah. Yeah, I appreciate that answer, and we appreciate your service, helping everyone out, but understand the dilemmas, facing surgeons as well.
Absolutely. I think there's very significant amount of distress among surgeons. I think it's clearly a sacred profession, but they are under assault. So are physicians.
David, Charlie here. Before I turn it over to David Demers for a question, and thank you for raising your hand, David. A couple of things you said raised questions for me. The example of House, that TV show, to me, he was a maverick. And I think when you think of medicine not so much as a science, which there is science, of course, in it, as much as an art, I think in the toughest cases that House dealt with, there's a lot of mavericks among the high-level surgeons of the world. Unfortunately, like I think you said, they do get persecuted by licensing boards in their states, which are somewhat politicized. They're made up of peers that may not like the limb out on which these mavericks go. I'm thinking of Brzezinski in Houston, who almost lost his license. And I think the persecution of mavericks goes along with another quote you mentioned about doctors should be respectful of non-consent after information. informed consent also implies tolerance of non-consent if the patient disagrees with your recommendation after they've repeated it back to you. And you also quoted Montessori, which is a very freewheeling, kid-respecting model of education that very many sophisticated parents have seen a lot of success with parents. And finally, the advanced payment frustration, burying doctors with new tech solutions and leading them to plead for a timeout. We're going to get universal health care because we already have government distortion of health care. If the doctors don't take your presentation seriously and go for the cash patient model, go for independence as a way to get that equanimitas that you mentioned, that to get refreshed, to be flexible like Montessori, to respect non-consent, and to be brave, to be a maverick, to give patients what they need, irrespective of the consequences. How do you respond to that mouthful?
Well, I think you raised multiple very important points. What's the difference between education and training, for instance? If you read practice parameters, and I've been responsible for writing practice parameters with a group, and I've written the practice parameters for diverticulitis and for anal cancer, and believe it or not, for hemorrhoids. And if you look at the data behind it, there's not as much high-level data as we'd like. High-level data meaning multiple trials that all agree and they're well conducted. Much of it is expert opinion as opposed to high-level data. So we are always very careful when we write society practice parameters to say that we recognize that there's more than one way of treating something, and nothing in these practice parameters implies that these are the only ways to treat it. And now that we're careful to put level of evidence that upon which each recommendation is based. So that's one aspect of answering your question. Another aspect is the rubric of the disruptive physician. So there are physicians that are truly disruptive. As chairman of surgery, I've seen physicians that behaved with such anger towards nurses that they were afraid to raise issues. And that is a problem. That's a quality and safety problem. On the other hand, it can be used, the rubric of the disruptive physician can be used to silence dissenters. So you need somebody with good judgment to be able to adjudicate these things. There's a great book, Why Hospitals Fly, and I'll go into it if there's time later, but essentially it deals with resource management and how pilots are trained to interact with each other for safety in the cockpit. And of course it goes along with the Motorola way in Kaizen, where anybody in the assembly line is empowered to stop the assembly line. And lastly, you talk about mavericks, and that requires good judgment too, because there are people that are doing, for instance, operations that are not scientifically based and are most likely harmful, and that are motivated by the desire to make money. And then there are true mavericks, and sometimes the line is very thin, and the best example I can give of that is Tom Starzo from the University of Pittsburgh. And he was doing liver transplants, and a lot of patients were dying. And the chief of surgery there said, this is the only operation I know with potential 200% mortality, because the donor and the recipient could die. So sort of a clever thing, but people were treating him like he was a criminal because he had all these deaths until the procedure was refined. But now liver transplant is life-saving for so many people. So was Tom Starzo a hero, or was he a bum? I think he was a hero. But there are many people, and you shouldn't really be experimenting on people. And there are people that some would call a maverick, but their motivation may not be good, or they may be deluded. And it takes a lot of judgment to tell the difference sometimes.
Very good. And there's more to talk about there with persecution of mavericks and those disrespectful of non-consent and the whole Montessori model for a more creative workplace. Dave, I see you have a question. Go ahead, Dave Demarest.
David, on your topic of joy in medicine, it's my observation that patients have a responsibility to put staff at ease. And I recall an experience when I had some surgery, and I was able to kind of a coincidence, I was able to inject a little inspirational levity into the surgery situation that helped everybody involved. Have you had similar experiences either in practice or in the education process on advising future doctors to facilitate patient involvement in the joy process?
Well, David, that's a very perceptive question. I think the difference between a service and a product is that any service is co-produced. So if you don't give your attorney honest information, he can't do a good job on your behalf. And if you don't give your accountant honest information, she can't do a good job on your behalf. And likewise, if you don't interact properly with your physician or surgeon, it makes it more difficult. So as a patient, if you bring a certain positivity to the relationship or interject humor, which is always good, I believe that the therapeutic relationship is easier to develop. Now, I do think that the physician and surgeon has a special responsibility because the patient is coming into the relationship. They're worse, they're often anxious, especially if it's a serious problem, and they may not be trusting after things they've read in the newspaper, things that tend to alienate the physician from the patient. So the surgeon has a special responsibility to try and establish a patient who may be anxious or angry or in pain. But there's no question that the doctor-patient relationship is co-produced, and the patient that brings a positive attitude and a sense of humor to the relationship is really helping themselves. There are definitely patients who are stepping on their own foot by, in a sense, outsmarting themselves. So I think it's a good question.
David, I'd welcome your colleagues at the American College of Health Trustees to build on your joy comments from the Trustees organization. Maybe Carl Middleton, do you have a comment?
Yes, I do. Can you hear me okay?
Yep.
Great. First of all, I thought it was a great talk, David. I do have a question, and it's, you had stated earlier in response to a question about distress that physicians feel. Research is showing today that one of the most significant problems that physicians, and I'm sure surgeons will experience as well, is what we call moral distress, where that the environment is such that it confuses the physician, and the physician then makes could be unethical decisions or be coerced into doing things that he or she would not feel is appropriate. What do you see as part of the answer to dealing with the moral distress that is being documented and researched on among physicians today?
Well, that's a great question, Carl. And for those who don't know Carl is a great ethicist. He's the American College of Healthcare Trustees Senior Vice President of Ethics, and our Chief Operating Officer. And also Carl was the Vice President of Ethics and Theology for Catholic Health Initiatives for 40 years. And he's the head of the Colorado Ethics Forum. And as you know, Carl, Trish Davidson, who's the Dean of Nursing at Johns Hopkins, has in her department Cinda Rushton, who's a nurse PhD, who studied moral distress mostly among nurses, but also among physicians. And there's a big body of knowledge on moral distress, which comes about usually because you feel that you're not being allowed to do the things that you think are right. So among nurses, moral distress is frequently caused by, for instance, having too many patients, so they can't devote the time that they need to the patients. Or in a sense, it's caused by not having enough authority. For physicians and surgeons, it's the same. How can you see a patient in your office for 15 minutes and deal with depression, chest pain, whatever, and counsel them about their medications? It's just not possible. And you know you should be doing it, but you can't. And if you spent more time, the administrators would be on your back, and or if you're in private practice, you wouldn't be able to pay your bills. So that causes moral distress. And, we are looking for solutions to that. And I strongly believe that it's improving the doctor-patient relationship by using this this platform of the cash patient is going to be very helpful, because it frees the physician up of having to fill out the electronic medical record just to justify an EM code. You just have to fill out what's needed for continuity of care, which is why the electronic medical, or why the medical record, the progress note, was developed. So I think that that's very helpful. And then we have solutions using virtual scribe and other things to improve the physician's productivity, to improve the patient experience. But again, I think moral distress is a real problem, and it causes physician burnout, physicians leaving the practice of medicine, or perhaps becoming cynical and less empathetic. even
It's
financial
It's hard to have
problems.
joy.
Even
It's hard to have joy in a situation.
Yes, absolutely. It's hard to feel joyful when you don't feel you're delivering the type of care you want, or if you feel you're not providing for your family. Uh, if you remember Tom Mua, who's a PhD in psychology, and he gave a talk at our meeting in California, and he talked about the fact that 16% of employees are actively sabotaging the hospital, and probably 50 to 60% are just clock watchers. They're not really engaged in improving, and only a small portion at the end of the bell curve are engaged in improving the quality and safety and patient experience. But you can improve that by relieving student debt, by helping with retirement plans, by giving financial literacy, and by providing the tools they need to provide the patients with the care they feel the patient should have.
Well, on that note, David, I want to thank you for a fantastic presentation on regaining joy for the art of medical practice. You want to let folks know one last time how they can reach you at the American College of Health Trustees?
Yes, thank you. By all means. So our website is www.facht.org. That's F as in Frank, A as in Apple, C as in Charlie, H as in Harry, T as in Tom.org. It's like a fact, except the H is thrown in. Or you can email me, call me, and I'm always available to talk.